was asked to give a CT chest talk at your academic half day this afternoon. It's June the 6th, 2012. This is available to you on YouTube. I anticipate to be there at the end of the presentation to answer any questions, so jot some down if you have any. Otherwise, let's go ahead and begin. So what we won't cover today is CT chest for pulmonary embolism, which is a talk in itself. As well, although very important, is again a talk in itself, the cautionary aspects of CT chest. And I would certainly suggest that you go to resources that will be outlined at the end of the presentation to look at the cautionary issues related to CT chest. But the ones that I would highlight would include radiation dose and how you can explain that to your patient, how to manage patients who require a CT chest when they're pregnant, and whether it's a safe modality to use. There's a very good up-to-date document on this as well. Talking to your local radiologist is very helpful to understand the local experience. As we all know, there are issues with renal disease and patients who have allergies to contrast. And worthwhile again to be familiar with these, as a CT chest is something we commonly use in our patient population. What we're going to focus on today are the patterns of CT chest and how they relate to specific diseases. And there's 4 different patterns I think are very important to outline and feel comfortable with when you're looking at a CT chest. The first is a reticular pattern, which when you look at the CT chest is described as septal lines. Nodular, the last 2 are high attenuation and low attenuation respectively. And within these 2 attenuation differences, the high ones include ground glass opacities and consolidation, whereas the low ones include emphysema, cystic lung disease, and honeycombing. In many ways, CT scanning works similar to X-ray examinations. It's certainly a form of radiation. The light or the radio waves can be directed at the body and different parts of the body. With CT scanning, the X-ray beams and electronic X-ray detectors, rotate around the patient. And at the same time, the examination table is moving through the scanner, and the X-ray beam follows that spiral path. In some ways, the analogy that could be used is the image is being sliced like a loaf of bread into very thin slices, and the image slices afterwards are reassembled to make a multi-dimensional view of the body. The technology has been so refined that you're able to now obtain multiple slices in a single rotation, and these are called multi-slice CT or multi-detector CT. They allow thinner slices to be obtained in a much shorter period of time. In fact, the CT scanners are so fast, or at least some of them are, that large sections of the body can be reviewed in just a few seconds. On that note, there are different types of CT chests. High-resolution CT chests are extremely useful, specifically for interstitial lung disease. They provide very thin cuts, and because of that, provide spatial resolution, so the parenchyma, the lung tissue, is visualized quite well. 2 other circumstances that we commonly see questions being asked to us is when to use contrast. Contrast, I tend to use that when I'm looking at the mediastinum or vascular structures. Other times would include chronic pleural disease. And the reason it's useful in that circumstance is that the inflamed pleura can take up the contrast and you can get some better definition to tell you a little bit about how chronic the process is. Non-contrast is a good regimen to start to assess the lung parenchyma, but clearly if you're looking at lung parenchyma for interstitial lung disease, HRCT is a very useful choice. So this is the most important slide, and the reason it is most of the CT chest abnormalities can be explained terminology by understanding this diagram. 2, can be explained pathologically, and 3, clinically. So just to go over this, this is the pleural lining here. This is the lung parenchyma, and you're following a large airway into a smaller airway all the way down here, and along with it comes the blue pulmonary artery, deoxygenated blood in this circumstance, and the pulmonary vein, which would be coming from, rather, the alveola out back to the left atrium through the pulmonary veins. Outlining the secondary lobule is the lymphatics and pulmonary veins, right there. And within the secondary lobule is the airway, which then breaks into the terminal bronchioles and into the alveoli down here. And this is what a CT chest looks like here. The arrows are pointing to an area that would include a secondary lobule. That would be many secondary lobules in that area, in fact. This is a blow-up, zoomed portion of that. And here you see the terminal bronchiole going into the alveoli, and the thin septae around the outside there. Again, the diagram. So keep this picture in your mind, because as we move forward, this is how we're going to describe those 4 pathologies outlined earlier, those 4 patterns. So the secondary lobule, just to reiterate, the basic anatomic unit of the pulmonary structure. It's the smallest lung unit, surrounded by the connective tissue septa. It's very small, measures about 1 to 2 centimeters, and made of several pulmonary acini, alveoli, are seen in the acini. Supplied by the terminal bronchiole and paralleled by the artery, known as the central lobular artery, and the pulmonary veins, as well as the lymphatics around there. I'm going to skip this slide. It's just another diagram of what we just mentioned. So there's a couple concepts, but the 2 that I want to start off with are centrolobular and perilymphatic. So the centrolobular area is the center of that secondary lobule, right in the middle there. And it usually is the site of disease where diseases that enter through the lung airways. In opposition to that is the perilymphatic areas. So these are the peripheral parts of the secondary lobule that was outlined earlier, and they're the site of diseases that occur along the lymphatics. So moving to a CT chest, the first thing we should do is assess for the dominant pattern. It's reticular, nodular, high or low density. The second step, as outlined just a moment ago, is where in the secondary lobule is the pathology occurring. And then thirdly, the distribution within the total lung. Is it upper or lower, central or peripheral? And we're going to take our steps, starting with this one, all the way down to this today. The first pattern is septal thickening, and it's just that, thickening of the septa that we saw by fluid, fibrous tissue, or infiltration by cells, and it results in a pattern of reticular opacities. So again, the septal thickening in this area, and outlined here more predominantly. When you look at septal thickening, it can either be smooth or nodular. Invariably, the illnesses that we associate by radiological analysis with smooth septal thickening are lymphangitic spread of cancer, interstitial pulmonary edema, or alveolar proteinosis. Whereas nodular or irregular septal thickening can again be lymphangitic spread of cancer, but sarcoidosis and silicosis are very common findings, specifically sarcoidosis, when you see nodular septal thickening. So here's an actual CT chest. In this area, you had have 1 or 2 secondary lobules, outlined by the septa, terminal bronchiole, the airways, and the acini in the middle. This patient has a malignancy, and you can see here, this is a large mass, the heart in the middle, and some bifurcations of airways. And the spread of the cancer is just that, through the lymphatics. And you get smooth lymphatic. Smooth septal thickening through the lymphatics. When you look at the X-ray, lymphangitic carcinomatosis, or more specifically, smooth septal thickening, looks very reticular. Increased lung markings, both sides. However, if you look at this CT scan, where the red arrows are, it's quite evident that along the fissure, the septa here, there's lots of little nodules. You get that impression everywhere, actually, along here as well. Nodular septal thickening. And this patient had a history of rash on their legs, shortness of breath, and wheezing, all consistent with sarcoidosis. When we take it a step back and look at the X-ray, it's difficult by an X-ray to really clarify whether this is smooth or nodular. But you would be swayed to feel that there is certainly a interstitial pattern bilaterally, more upper lung zone than lower lung zone, with perhaps a little bit of hilar adenopathy. And that would be consistent once you got the CT, of course took the history with sarcoidosis. So moving from septal thickening to nodules. There's three types of nodules when you look at a CT chest. The first is random, the second centrilobular, and the third perilymphatic. Starting with centrilobular, the previous diagram of this secondary lobule showed you a little dot in the middle of the secondary lobule, and that's exactly where the centrilobular nodule would reside. They usually are about 5 to 10 millimeters from the pleural surface. And unlike perilymphatic or random nodules, they spare the pleural surface. Now, you don't see any nodules on the pleural surface there. Now, you don't necessarily have to have one, you can have many. It can be in different places, but they tend to be, again, in the middle of the secondary lobule. Perilymphatic are nodules seen on pleural surfaces or along interlobular septae, where the peribronchovascular interstitium is. And simply put, the nodules are seen along the pleural surface, but they're also seen along fissures that may delineate the upper and lower lung, and this would be considered perilymphatic, and they'd be going along those interlobular septae of the secondary lobule as well. And lastly, random. Well, these nodules don't have any relationship to the lymphatics or septae, nor do they reside solely in the middle of the secondary lobule. They tend to be everywhere. The reason that it's important to distinguish the type of nodules that you're seeing is the differential diagnosis. So here, with multiple nodules, if you see no pleural nodules, right away you're pretty confident you're likely dealing with centrilobular nodules. These are airway-driven processes, such as respiratory bronchiolitis, infectious diseases like mycoplasma or TB. Some cancers can, like bronchoalveolar carcinoma, and some ILDs, such as hypersensitivity pneumonitis. HP, abbreviated, is usually a reaction, an immunological, inflammatory, or allergic reaction of the lung to an inhalant, to an antigen of some sort that needs to be breathed in, and that's why at the beginning of this disease you see nodules in the central areas of the secondary lobules. If you were to see a CT chest and saw nodules but no pleural nodules, the next step would be to delineate whether it's along the septa or the fissures on the pleura, because if it was, it would be perilymphatic. And very similar to nodular septal lines, the differential is sarcoid, silicosis, and lymphangitic cancer. And by a matter of elimination, if it's not centrilobular or perilymphatic, you're likely dealing with random distribution. And the common diseases we consider are miliary infections and hematologically spread cancers. The miliary infections are TB and fungal, or cancers that are hematologically spread are more common. And again, just to highlight, there is an overlap in the differential diagnosis between perilymphatic and nodular septal thickening, as outlined. And that's why there are certain terminology used by radiologists or clinicians when seeing this pattern of overlap, and they call it reticular nodular. So we've already seen this CT chest where you had perilymphatic nodules. What about these two here? So the yellow arrows just pointing out some nodules. Are those perilymphatic, random, or centrilobular? And similarly on this CT chest. Both of these are from the upper lobes and segmental representations of what is occurring in the whole CT chest. So if you said centrilobular here, you'd be correct. Reason being is there's no pleural nodules. You might get tricked into feeling this could be along the septa, but you don't see any other perilymphatic nodules elsewhere. And they seem to be evenly spaced, and there seems to be a boundary between the nodules. Lastly, there seems to be a space between the pleural surface and the nodule. And those are all definitions that would fit more likely with centrilobular nodules. This was a patient with mycoplasma pneumonia. When we look at this one, it's a randomly distributed pattern. The reason being here, if there are nodules on the pleura, there's some 5 to 10 millimeters away from the pleural surface, and there's some on the septa there as well. So it has a bit of everything. And this was a patient with miliary TB. So here you have perilymphatic, sarcoid, centrilobular mycoplasma pneumonia, and randomly distributed miliary TB. So the clinical diagnosis came from the overall pattern of the CT chest. Skip this slide. So what do we see here? See some nodules. They seem to be on a stalk and emanating from a central area. They don't seem to be associated with the pleura. Really doesn't seem in conjunction with any septa. So you would think centrilobular, but this pattern is kind of unique, and it looks more like a tree on a bud, and that's exactly what it is, a tree and bud sign. And here's a better representation in this lower CT chest cut. So you're following this inflamed airway, which we'll get to in a couple slides, all the way out, and you see this white thickened stalk with little buds on a tree. Well, what that white thickened stalk is a terminal bronchiole that transverses a secondary lobule, and the little dots are mucus-filled alveoli. So the septa would be something like this, the terminal bronchiole into little alveoli, and that's what you're seeing. So what does a tree and bud mean? Well, it helps you narrow down the differential of centrilobular nodules, and again, they reiterate why that's the case. Here's the septa, pleura, the terminal bronchiole with the alveoli. It's mucus-impacted airway. It's filling of the alveoli and the terminal bronchiole. And things that tend to cause this to occur include infection, like MAC or TB, but it's not always TB. It's certainly associated and commonly dictated out as must rule out TB. Other things that can cause it are airway diseases that cause a significant amount of mucus, so cystic fibrosis or bronchiectasis. Lastly, patients with ABPA. So anything that causes mucus impaction of that terminal bronchiole and the alveoli situated within the secondary lobule will give you finding of tree and bud. Alright, so we're going to move from nodular pattern to a high attenuation pattern. So same secondary lobule, same terminal bronchiole, pulmonary artery, septa, and the pulmonary veins. We're going to talk about ground glass opacities and consolidation. So a ground glass opacity is just that, an opacity that's got a glassy appearance to it, whereas consolidation is just a dense increase in the lung opacity. The main distinction between these two is with ground glass opacity you don't have any obscuration of the underlying vessels, you can still see them, whereas with consolidation it's not uncommon to lose the vessels altogether. But in both of these processes, the increase in the density, the high attenuation, is replacement of the secondary lobule components with fluid, cells, or fibrosis, or a combination of all three. Okay, so that the areas, the parenchyma, and the alveoli are now filled with these secondary processes. And by just looking at those three terms, you can come up with some pretty quick differentials. And if you had a history, you could certainly narrow down to a provisional diagnosis. So ground glass opacity, as we mentioned, it's usually filling of the spaces with pus or edema, blood, inflammatory cells, even tumor cells. And there's associated thickening of the interstitium, the lung parenchyma, as well, because of inflammation spreading everywhere, the alveolar walls. But usually those changes are so far below the spatial resolution of a CT that you can't really see the actual inflammatory changes, but only fibrosis if it is there. And just by that little description, you can see there's quite a few things that can cause ground glass opacity, so it's very non-specific, and you have to use history in the physical and all the lab investigations to narrow down that differential. But one helpful way to break it down is into acute changes and chronic changes in regards to the ground glass opacity, which I'll abbreviate GGOs. So acute changes usually are pulmonary edema, blood, pulmonary hemorrhage, pneumonias, specifically viral or atypical. Chronic changes, any airway distributed process such as hypersensitivity pneumonitis, whereby again you have an antigen that you're inhaling. It can cause an intense inflammatory immunological response in the lung but in the secondary lobule, and you can get similar findings of ground glass opacity. Other chronic ground glass opacities would be alveolar proteinosis and bronchoalveolar carcinoma. So here's a cut from a CT chest. This patient was dyspneic. It was a subacute presentation, and they had a collagen vascular disease. If you had the whole CT, in which we don't, this was more of a lower lobe predominance. And so of the things that are on the differential for ground glass opacities, with connective tissue diseases, you'd probably be swayed to more of an inflammatory process, and that in fact is what it was. It was non-specific interstitial pneumonitis, and pneumonitis in this case being an inflammation of the components of the secondary lobule related to the connective tissue disorder. NSIP is an idiopathic interstitial lung disease, and this is what it looked like on chest x-ray. You wouldn't be able to make that diagnosis from the chest x-ray, but you would, by history and physical and x-ray, moving on to a better test like the CT scan, be able to narrow that down, and this patient would go on to get a lung biopsy to confirm the diagnosis. So moving to consolidation, another high attenuation finding. You really want to think about what is replacing the air in the alveoli when you think about consolidation. And it's usually pus, edema, blood, or cancer cells. Acute consolidation, chronic consolidation. Very similar to GGOs, you want to differentiate based on time, because if all you had was a CT chest, it'd be very difficult to say what's going on. And very similarly to ground glass opacities, you have a consistent differential between the two. This is pretty much lumping it all together. So if you remember this slide, that would essentially be your differential for both consolidation and GGO, but the finding or pattern on CT chest will distinguish between the two, as will how acute or chronic each of the conditions were for that specific patient. Here's an example of someone who had easily recognizable high attenuation changes on the CT chest, or consolidation, or filling of that secondary lobule. This patient had dyspnea for 4 months, and this occurred, or the consolidation occurred after the patient was treated for the pneumonia. So this finding persisted, or even got worse after the pneumonia that made the patient dyspneic was treated. What kind of thing would you think about? Well, on chest x-ray, before we answer that question, this is what it looked like. Very dense opacities in the periphery of the x-ray. And this is what the consolidation would look like on x-ray. And the patient actually turned out to have what's called cryptogenic organizing pneumonia, previously known as BOOP. So we've talked about septal lines, different types of nodules, high attenuation patterns, and now I want to just stop and take a moment to talk about low attenuation patterns. And there's several within this category, and they include honeycombing, traction bronchiectasis, lung cysts, and centrolobular emphysema. When in fact, I should take that back and say emphysema, and I'll clarify that in just a moment. To start at the top there, honeycombing is defined as small little cystic spaces that are irregularly thickened walls. The cysts predominate in the peripheral area of the lung, usually in a subpleural region. Now, bronchiectasis is localized bronchial dilatation. And a lung cyst is a radiolucent area with a wall thickness less than 4 millimeters. Whereas a cavity is, again, a lung cavity, but defined as a radiolucent area with a wall thickness of greater than 4 millimeters. I point this out now. This is a good slide to bring this to your attention. A cyst has a wall. You can see that quite clearly, as does a cavity. Again, the thickness would differentiate between the two. But emphysema, they're radiolucent areas as well. But in conjunction, they don't have walls compared to the cysts or cavities. Now, I haven't highlighted emphysema because there's several different types of emphysema. There's paraseptal, panlobular, and centrolobular. And they do have some clinical correlation, which I want to highlight right now. So paraseptal emphysema is, if you look at the secondary lobule, the septa are now destroyed. Paraseptal. We tend to see these in younger individuals who, for whatever reason, get spontaneous pneumothoraces, probably because of the anatomical and physiological changes associated with the emphysema. Panlobular, this occurs in patients who have alpha-1 antitrypsin deficiency, but in those also who smoke quite a bit and have more pronounced and progressed emphysema. Panlobular is just that. The whole secondary lobule is now destroyed. And not one, but several millions would be destroyed to cause this change. And the reason it's low attenuation is, if you compare it to the lung tissue that surrounds it, here and here, this is all air-filled, and it's going to be lower attenuation. And the all too common, or less uncommon, I suppose, centrolobular emphysema, which is strongly associated with smoking, usually an upper lobe predominance. And as we outlined in the previous slide, there's no defined wall, but it's low attenuation compared to the lung tissue around it. So moving on from emphysema, go to the second low attenuation finding, which is bronchiectasis. As I mentioned earlier, bronchial dilatation is very common. But But along with the dilatation of the bronchi, you see bronchial wall thickening. And the way you diagnose it is to look for the dilatation and the thickening, but also to recognize that airways normally taper or get smaller to the point where they become invisible as they get further out. In someone who has bronchiectasis, that dilatation and thickening persists well out into the periphery. Associated findings would also include mucus retention within the airways, and in some cases, as we outlined in the previous slides, with the mucus retention you can get a tree and bud finding if the mucus tracks all the way down to the secondary lobule and into the alveoli. Not great examples, but I do wonder if we zoomed into this area here, whether some of those findings, little dots, would be associated with terminal bronchioles and represent tree and bud. When you look at an X-ray, hard to really diagnose bronchiectasis on an X-ray. Again, the history and the physical is helpful. For instance, if you had cystic fibrosis with increased lung markings in the upper lobes, you certainly would keep it on your differential. But this X-ray is of a 60-year-old with recurrent pneumonias, and the CT chest went on to find the lower lobe bronchiectasis. What you do see, if you put a line through the middle to delineate upper versus lower, is a perception of increased lung markings. But again, it was a CT chest finding of low attenuation changes with bronchial dilatation, airway thickening that made it the diagnosis. And if someone has such significant bronchiectasis, they would be at higher risk of pneumonias, and you would want to institute a very similar treatment plan as you would with a COPD patient, with specific understanding of why the bronchiectasis is occurring and management for those etiologies. I want to turn our attention to a different pathology now. It's one we outlined earlier, cystic lung diseases. So again, these fall into the low attenuation. I'll just skip right to the CT because it's air-filled, and compared to the lung parenchyma beside it, it's low attenuation. It's cystic because the walls have a thickness less than 4 millimeters. And in this patient, there's many examples of that. You can even make the argument that maybe some of the areas are greater than 4 millimeters and could be close to falling into the cavitary category. But for argument's sake, let's say it's just cystic disease. I throw up the X-ray because this is what cystic diseases look like on an X-ray. Not the best example, and may not show well on the projector screen, but there are some areas of lucencies on both sides of the lungs. This is a 40-year-old gentleman with hemoptysis, and wouldn't surprise anyone, I would presume, that this patient has abnormal airway function, and microorganisms likely live in this area, and inflammation and disruption of vessels would lend itself to increased risk of hemoptysis. And here is some differentials for cystic lung disease: lymphangioliomyomatosis, otherwise known as LAM. That's how I'll say it from now on, if I have to say it. Langerhans cell histiocytosis, known as eosinophilic granuloma or histiocytosis X, at different periods of times in the past. LIP, pneumatoceles, and honeycombing. So again, you would use the history and the physical and the pattern, which is low attenuation, less than 4 millimeter walls, and a distribution, if you had the whole CT, of the whole lung, but predominantly an upper lung zone. And I'm just going to go back to the previous chest X-ray. As you can see, if I put a line through the middle, most of the cystic changes are in the upper lung zones. Well, it's not actually unusual for Langerhans cell histiocytosis to have that distribution. LAM is a condition that exclusively affects women, although I believe there's one case report of a man who had it. Has cystic lung disease, and in this case tend to spare the claustrophrenic angles. Pneumatoceles, not unusual to see in development of the lung, but also in areas of trauma or resolving infection. And interestingly, the pneumatoceles, when they have cysts, if you took a CT scan today and saw one cyst in 3 to 6, 9 months, that pneumatocele would be gone. Here's here's an example of a 70-year-old dyspneic patient who goes to their GP for an X-ray. We'll talk more about distribution, but if I put a line through the middle here, there seems to be more interstitial changes in the lower lung zones than the upper lung zones. And if I was to put a line down the middle, the hemithorax, it seems like it's distributed on both sides. So lower lung zone predominance, shorter breath patient with this specific finding. Well, let's see what we see here. The secondary lobules are completely destroyed. They've been replaced with little cysts in a subpleural location that seem to be stacked on each other. There's associated findings of thickened, dilated airways that look inflamed, and perhaps some emphysematous changes, but certainly not the predominant finding. I think you would agree the predominant finding here would be two things. One, cysts that are on a subpleural location. And this is what we term honeycombing. And again, the honeycombing tend to occur in a subpleural region, and it's easily distinguishable from paraseptal emphysema because this emphysema is usually a single layer, whereas honeycombing tend to be several layers. The differential, very much related to interstitial lung disease and some of the idiopathic lung diseases that are chronic or progressive or end stage. So IPF, connective tissue disease related ILDs, drug related ILDs, occupational related ILDs, and end stage hypersensitivity pneumonitis, as well as end stage sarcoidosis. They can all have this final common pathway: honeycombing, traction bronchiectasis, lung distortion. Okay. We've been talking about distribution within the lung, and it's very helpful actually when you look at a CT scan to look at where the predominant pattern is occurring, irrespective of what pattern you're looking at. I had an X-ray and CT scan where I've cut them in half, or at least the X-ray I cut in half and showed you the upper and lower lung zone, and I cut the hemithorax in half and showed you the central versus peripheral. And I'm not going to go through this differential, you can do this on your own. But there are certainly certain pathologies that like to follow distributions more so than other, and you can use this information along with the pattern that you see to narrow down that differential to a provisional diagnosis that makes sense on the history, based on the history and physical. And just some other associated findings. It's always nice to look at the hyla, the mediastinum. Common findings we see there are lymphadenopathy, and things that cause lymphadenopathy are cancer, infections such as TB, sarcoidosis, and other occupational related pathologies such as coal workers or silicosis, even berylliosis. When we think about sarcoidosis, we tend to see the lymphadenopathy in the right paratracheal region and bilateral hilar adenopathy, otherwise known as the 1 right paratracheal, 2, 3 bilateral hilar adenopathy sign. Lung cancer and lymphocytic carcinomatosis can cause adenopathy, and they, not by rule, but generally are found to be unilateral. If you have eggshell calcification in the lymph nodes, so there'll be a little calcification around the lymph node. This commonly occurs in patients with silicosis or coal workers, so occupational changes, but as well in patients who have burnt out sarcoidosis, a very long-standing sarcoid, or those who have Hodgkin's disease that have been irradiated. Other times you see this are with fungal diseases and occasionally scleroderma. Coming to the close here, and I just wanted to summarize what we've seen and to emphasize that it really just goes back to the anatomical understanding of that secondary lobule. So this is the CT chest here, the pleura. The terminal bronchiole coming down to the secondary lobule, which is has a boundary of the septa. The pulmonary artery, which is blue, deoxygenated blood, following the terminal bronchiole. The pulmonary vein, which goes around the lymphatics, which are in the septa. And as we go down the terminal bronchiole, they split up into acini and alveoli. Between the airways, the vessels, and the septa is a lung tissue. And everything that we've talked about, the 4 different patterns of CT chest, will be seen in relation to the changes in the secondary lobule. So the first step is to look for the dominant pattern, reticular/septal, nodular, high density or low density. To look at the distribution of where the changes are in the secondary lobule, specifically helpful for nodules. And then to help narrow the differential even further, even without knowing the history, to understand the distribution. Is it upper or lower, central or peripheral? To recap, the first thing we looked at was septal thickening. If it was smooth or nodular. Nodular, beaded if you like, tends to be sarcoid or silicosis, even cancers that are lymphangetically spread, whereas smooth can be lymphangetic spread of cancer, but edema as well. We also talked about nodules, and a quick way to figure out which of the 3 type of patterns you're looking at is to assess for pleural nodules, and if you don't see them, you've got right down to the central lobular distribution, which can be broken into any airway distributed pathology. Whereas if you see pleural nodules, to understand if they're related to the pleura, the septa, or if there's a fissure here, the peribronchovascular areas, which would be perilymphatic, and again you have your differential. And if it's neither of those 2, it's likely random, which is very evident usually, and you have a specific differential there. To subcategorize centrolobular, you can look at pathology, which represents tree on a bud, and you have any airway driven process related to mucus. We also talked about high attenuation patterns, ground glass versus consolidation. And the differential between the 2 are very similar, with some exceptions, but very useful to break it into acute and chronic, so you can get a better understanding of what is occurring. And lastly, we talked about low attenuation patterns, and the 4 that are useful to remember are honeycombing and the differential for that, very much end-stage fibrosis, traction bronchiectasis, bronchial dilatation, airway thickening, associated mucus, airways being quite visible in the periphery of the lungs, cysts and cavities based on thickness of the wall, and emphysema, 3 different types, paraseptal, centrolobular, and panlobular. And to remember, emphysema, unlike cysts or cavities, do not have a wall. And emphysemas, those 3 that I mentioned, have clinical correlations. So bronchiectasis, honeycombing, and cysts. Cystic lung disease has a differential that quite unique and some less than commonly seen pathologies. And again, to know the secondary lobule, the pattern that you're seeing, where is it, both in the lobule and the whole lung, And then you'll come up with a hopefully with a familiarity, comfort zone, and a good differential, perhaps a provisional diagnosis, just based on the CT chest alone. All the slides that I've just mentioned and described here are also available on Radiology Assistant, and again, this video is available to you on YouTube. Thanks a lot, and if you have any questions, you're welcome to give me an email. Cheers. Bye.